mode. All right. Well, so Neil and I really appreciate this invitation. We think these meetings are a great idea. Of course, I have great respect for your work. And right now, we're going to try the impossible task of describing the competency challenge and the consent decree in about 15 minutes of rapid fire slides, followed by some time for questions and discussion. And of course, I'm going to take the easy part, which is presenting, and then I'm going to leave Neil to handle the hard questions that come up. Both of us are just to quickly clarify, both of us are appointed by the federal court as the special masters in the longstanding litigation brought by DLC against the department. And both of us have been working really closely with DLC and the department and seen some really remarkable efforts to address a tremendous challenge. We want to start by saying this challenge is not at all unique to Colorado. This is it's called a national competency crisis because so many states are feeling this. There are increasing orders for competence evaluation. This national estimate that used to be given for decades is just woefully low, should be much higher. There are increasing orders for competence restoration, of course. And there even seems to be an increasing proportion of defendants found incompetent. Used to the widely cited figure was about 25–30%. And that has almost doubled in every state of which we are aware. Colorado included has an incompetence rate. So among the people referred for evaluation, about half are found incompetent. So something has really been changing around the country and in Colorado. Here you're going to see some Colorado figures up to 2018. So kind of taking us up right to the start of the consent decree. You'll see that kind of steady increase there. You'll see the orders for inpatient restoration treatment just exponentially increase in those last several years before the consent decree. And then when we include these recent years, you see sort of a pause when COVID hits and the system slows down, but really quickly escalates again to some of the highest ever. And so again, it's not hard to see what a challenge this creates, right? More orders, more people found incompetent, more people then waiting for inpatient restoration services. And there really creates an overflow, right? Where the incoming referrals and orders are far exceeding the funnel, if you will, or the exit to inpatient restoration. And again, I want to emphasize this is happening all over the country. Generally, our populations do not get a lot of media attention, the people we serve and work with. But here you'll see that this has really started to happen, right? This is such a crisis that there is that much attention. And you see some of that in Colorado, right? Here's just a sample of the Colorado media attention. In many, many states, this has prompted legal action. Advocates bring suits just as they've done in Colorado. And then many state systems come under consent decrees, just like Colorado has. So again, this is not unusual. This is an exemplar, Colorado is, of a national crisis. And as many of you know, and apologies to some of you on the call who know this just intimately well, our sense was that some people would be very familiar with this, some people would not. And so we are going to just sort of briefly overview the path to the consent decree. Disability law, Colorado brings this lawsuit. The parties negotiated for resolutions. These were, the kind of remarkable negotiations where everybody gives up something, everybody commits to something challenging, and these result in this consent decree of March 2019. And this consent decree delineates a number of plans, a number of commitments the department is making to reduce timeframes, for detainees waiting for evaluations and restoration. It designates fines when they're not able to do so. This is all very standard for consent decrees. This is common. Some of the less common elements are the actual clinical intervention. So creating a triage system. This is actually unique around the country, the idea that you would triage people waiting for competency services. It sounds so basic, but this really was, quite a breakthrough, we think, to prioritize those who are sickest and at highest need for more rapid admission. And then, of course, you develop a forensic support team to support those populations. And we think of we kind of think of the consent decree in this way, with three broad goals, right? Reducing the number of people on the wait list, reducing the time they spend on the wait list, and reducing the harm they experience while waiting. As you all know very, very well, waiting in a jail while you're psychotic for hospital level treatment can really be harmful, right? Many states, including Colorado, have just some heartbreaking examples of what happens. So these are some of the major initiatives. This triage system, again, among the most unique of them. Competency service systems have always worked like the DMV, for example, where you come in, you take a number, and it does not matter if you are severely psychotic or intellectually disabled. You're just sort of in line in kind of a regular queue, and nobody is triaging who is most urgently needing treatment. And the consent decree made this different, made this more like a hospital emergency room where people are triaged by their level of need, because not everybody requires the same treatment or the same timing. Again, as many of you know, this was operationalized as a tier 1 and a tier 2 designation among those people who have to go to the hospital. Of course, there's also many people who can be restored in the community. And here, Colorado actually has become a leader. It's one of only 2 states with statewide outpatient restoration. The proportion of defendants who are directed to outpatient restoration is really quite high. Our system would be even more strained if this was not the case, if there was not this outpatient system doing so much service. So at the time of evaluations, you have evaluators offering opinions on these placement decisions. I'm going to move through these rapidly. And then you also have the forensic support team that supports the people who are waiting, because of course their condition can change, and we really need eyes on them to see if that condition is changing. Some people get worse as they're waiting and need even more rapidly to go into the hospital. Some people do improve and then become able to go to the community. So the FST works on this. They work often in concert with Bridges, which is not a department function, it's a court function, but they certainly work together in many ways. And so we end up with this continuum of care here in Colorado for restoration services. And again, a key part of this continuum is the outpatient restoration, which is now available statewide. You'll see referrals ebb and flow, but they're really quite significant, often with about 40% of the people evaluated referred to outpatient rather than inpatient restoration services. So again, here's the triage and placement decisions. I'm just moving through these very, very rapidly. One of the things we want to emphasize is that this consent decree really was working well. Now, you all know better than anybody that Colorado has had these long-standing vulnerabilities underneath, right? It's never had enough inpatient beds. It's always had some staffing trouble at the hospital. There's a lot of vulnerabilities there I don't want to gloss over. At the same time, in that year between the start of the consent decree and COVID, there was really some remarkable process, right? The wait list dropped into the single digits. Everybody who was designated tier 1 almost was in the hospital within 7 days. And then, you know what happens? COVID hits, and for a moment, referrals are down, the system has slowed. But then things get very, very challenging. There are delays to admission due to quarantining and other safety precautions. There then become greater and greater staffing shortages, and the wait list has greatly increased, right? It's now around 360. And so we're in the midst of much greater challenges now. Now, again, in these, the triage, the FST, they remain crucial, but they probably are not sufficient for the challenge the state faces now, right? There is much more that needs to be done, that we do see the department working on. One of the things that has happened, and Vincent, we talked about wanting to make sure people are aware of this. The fines that the department has paid have gone into a fund that allows for some new projects. And in the first wave of projects, there was a lot to support housing, private psych hospital beds to supplement the hospital, a legal advocate. In the more recent wave of funding, we're more and more trying to prioritize sort of upstream interventions, right? Things like diversion, competency dockets that handle competency cases more efficiently and expertly. A number of interventions here. Neil can maybe get into more of these, but these funds are available for innovative projects that may really make a difference in the competency crisis, right? These aren't for the department to duplicate their services. These are for new additional interventions. And so we always encourage the people we talk to be thinking about these. Next steps, looking towards the future, we do see a need for more and more change and development. Again, we see the department and other groups working on these, but so many of these are going to have to start further upstream, right? Efforts like diversion, deflection. There are people who need treatment more than they need adjudication. One part of this challenge is misdemeanors, people who are facing just misdemeanor charges that are largely due to their mental illness. Really are not great targets for the lengthy jail wait and competence restoration process, right? Many of these people can be handled and served and helped so much more rapidly with the diversion. And so we do see, progress in that effort and hope to see more and more. But of course, you still have people who are very, very sick and who do need inpatient care. And so for those, we need this full continuum of care. Various inpatient and community placement options. This is what we see in the future. So with that, I think I have just hit our 15-minute mark, and I want to stop the screen share, open it up for maybe some comments from Neil, and then questions and discussion from you all who know many of these issues so well.
Yeah, thank you, Dan. I'll keep this brief because I do want to have plenty of time for questions. Obviously, it's a great overview, and Dan is exactly right in presenting this information, especially kind of the trajectory of the consent decree in which wait times and numbers on the wait list were decreasing substantially, but for the pandemic in which things have really turned the system all around Colorado, not just the competency system, but in so many areas that touch the competency populations, turned it upside down or made it go sideways. We have been in consistent communication with both the department as well as Disability Law Colorado to acknowledge the impacts of the pandemic, but also realize that it's a new reality. This landscape is here to stay and adjustments have to be made. If we were to create a consent decree today, it might not look exactly the same as the consent decree that was put into place in 2019. There may be some other parameters that would be included in there that are responsive to kind of today's realities rather than 2019's. I would like to echo the broad picture that Dan ended with. The competency system, this is lay language, and this is sort of just how I conceptualize the work that the department and DLC must do to solve this competency crisis. The competency system should be efficient, effective for people that need competency restoration. I think, unfortunately, what's happened in Colorado and many states is that people are being funneled into the competency system competency services system inappropriately. And there are many people who may need treatment first, or diversion, or deflection rather than competency restoration. People who are very sick need to have their clinical needs met as a priority, rather than, or sometimes to the exclusion of, any kind of pending criminal charges. And so trying to help the system, you don't want to incentivize forensic competency services as being the conduit to mental health care. And the concern is that by building up this kind of big forensic system, you do sort of incentivize that. And so what we're trying to do is right size it so that the civil capacity in Colorado really is the main front door for service connection, if you will, to borrow the term from the VA, and that the forensic system is really reserved for those people that truly merit it. And especially the hospitalization, only for those people that truly need hospitalization should be going to the hospital. So we'll go ahead and open it up for questions. I see some known faces and names on the screen, and then some people I'm not familiar with. So happy to answer questions in the chat, or, well, I guess Vince, maybe you can play MC here, how you like to take the Q&A part.
Sure, I'll do that, but I'll also just start off with a question, observation, and thank you both so much for your rapid fire but very clear presentation. Thanks, Dan. And then Neil, as you said just now, I mean, this is the crux of the matter, is that we've built up this forensic system and are sort of anemic or something on the civil side. And you know, I think that we see some legislation, some investments on their way to building things up a little bit on the civil side, but have you seen, or what have we seen nationwide in terms of addressing that imbalance? You know, I feel like this is the real crux of our problem. What I've been wrestling with as an advocate is, yes, diversion, and yes, treatment and care and support and services for the people who have health needs that have been unmet, but where is that? And what do you see in terms of hopefulness on the horizon for shifting that balance?
Sure, I'm happy to take the first response here, but Dan, if you've got stuff to chime in with, please do. It's a challenge. There's no way around it. I mean, as Dan mentioned, this competency crisis is happening in most states around the country. So Colorado is certainly not alone in facing this kind of challenge and trying to wrestle with, where do we put the right people in the right service with the right kind of settings and supervision? Some of this is, my response is going to be predicated on my experience, not necessarily as recommendations from the special master. I want to make that clear. These are things that we discuss, you know, with the parties involved, but this is, I'd like to preface this by saying these are not recommendations from the special master, okay? But things that we have seen be effective in some places are avenues for police and for courts to mandate people to community care or to community settings. Sometimes those can be supervised and monitored, sometimes they can be locked. Assistant outpatient treatment with, you know, a higher supervision and sometimes mandate for medication. Those kinds of things do seem to be making a difference in some places around the country. Involuntary medication for people who are in jails is possible in many places around the country, not so possible in Colorado. I'll be very frank, Dan and I review the list of people who are beyond their time frame for being admitted to the hospital and who are in jail. We review the notes for every person every week. So the person is in jail waiting to get to the hospital and they're beyond their 28-day time frame to get there. We're reviewing those notes every single week. And I think it gives us a pretty good picture on that minority, but critically important minority that is really acute and needs to get in quickly. At the other end of the continuum, some people that seem to be relatively stable, and you sort of wonder, maybe they've been, maybe they've restored to competence during their wait time. And then this larger middle group that is somewhere in between, still needs to be in the hospital, but not urgent. What we've seen is medication and consistent monitoring and treatment makes a huge difference into that population. But only in certain jails can that happen around Colorado. So I know some of these are, rife with controversy, and different people have different perspectives on advocacy versus, kind of forcing people into treatment. Those are things that other places have wrestled with in different ways. And I think it's up to Colorado and the legislature and the voters to determine what the best course of action is and where we fall on that continuum. But I will echo this, and I know it feels sort of like a cop-out to say diversion and deflection into a civil system, but that really is, I believe that really is the primary path to getting out of this competency mess. If the community is mandated to take those people, even if they have a forensic commitment and they have the resources to be able to serve them effectively. I'm not sure those second two components or predicates are in place in Colorado at this point.
Right. Thank you. So let's see, Elisa Witt has a question. Or Elisa Witt has her hand up. And
sorry. I was trying to unmute. I apologize. So I'm brand new in my role. I'm actually leading a very, very small county public health agency here in Colorado. So forgive me, I'm brand new to the party, brand new to coordinating mental health services and things like that. The issue came up that I wanted to ask a question about recently at a meeting between, it was actually for emergency management. So law enforcement, our ambulance authority was there. And what I witnessed was almost a debate between law enforcement and our ambulance authority about transporting patients who are having a mental health crisis. Neither agency wanted those patients. Not that they didn't want them. Our ambulance authority stated that a couple of patients that law enforcement had tried to send their way did not meet the definition for their ability to transport them, and pointed out the fact that many times when they do transport these patients to an emergency room, they're back on the street within 10 minutes. And we live an hour away, we're a rural county, from any healthcare facility. So then these patients are an hour away from home, back out on the street. Law enforcement is not comfortable transporting patients. They don't know where to take them. And like I said, ambulance doesn't feel that their meet the definition. So I was just curious if anybody had encountered this before and what I might be able to do to help facilitate a solution.
Thank you, Elisa, and welcome to your new role, I guess. And every county and every person is important. I don't have a good answer for you, unfortunately. So I was going to see if Vince wanted to open it up to the group for a response there, because I do not have a good response.
Sure, we can open up to the group, and I'll just say, Elisa, that yes, we've heard of this before. This seems to be one of the common themes of our advocacy at this area, is the first responders are reluctant to get involved in many cases because there is no there with regard to how to place somebody in these kinds of circumstances, other than just finding something they can charge them with and taking them to jail, and then ticking off this entire competency backlog issue, which is where we seem to be stuck. Anybody else want to speak to this?
I would, this is Michelle Barnes. At least I know this doesn't solve the big problem. I run human services. If you want to reach out to me, let me see if I can help you in your local situation and see if there's anything we can do to help troubleshoot.
Appreciate that, Michelle.
Yeah, the chat's not on Vincent, or else I just add my email to it. But at least you can get it from Vincent or anyone else. But Michelle Barnes at state.co.us.
Thank you. I've got it.
Happy to help.
I'm sorry about that. Thanks for joining us, Michelle. I didn't know about the chat not being on. Maybe Emma can figure out how to fix that while we're still on here today. I don't know how to do that.
Well, I see Michelle's email address is in her.
That's right on the
so
screen.
If you just kind of hover over her cell on Zoom, you'll see the email address there, most of it anyway.
Yeah, sorry, I noticed that Director Barnes was with us, and I meant to acknowledge her as well as Megan Baker from Disability Law Colorado, we have both sides of the situation represented with us today.
Yeah, I'm the one named on the lawsuit. So I'm always very interested to learn ideas from Daniel and Neil. So thank you for letting me be here.
Always welcome. Thanks for being with us. Judge Lath is with us as well and has her hand up.
Thank you. My question is, how does one apply for a grant from the fund?
That's a great question. And we figured, Dan and I were talking ahead of time, we thought we're probably going to see more applications for fines funded projects after this presentation than we have. A great question. At this point, we are revising the process. In fact, we have a meeting later today with the group that's going to be heading up that organizational part of the fines funded projects. But in lieu of that, I think right now, probably the best thing to do is just to email Dan and email me. And then once we get that process a little more down the road, within the next couple of weeks, if there's more information we can share with Vince about the best way to, the more optimal way to do that, we'll share that. But for now, I think just email either Dan or me.
Yeah, we're enthused about these. We typically have some conversation back and forth about how to build the strongest proposal. And then it would come to the committee for formal consideration. But because we anticipate higher volume, we're going to get a little more formal really soon.
What is the email?
Yeah, Judge Lath, because the chat's disabled, ordinarily we don't use our university emails, but I think for this, we could easily do that. So you can find me easily at the University of Denver. Oh, it looks like we might have a chat function now. Well, it still says disabled for me. I'll tell you what, if you can find me at the University of Denver, you can find Dan at the University of Virginia. If the chat allows us to put those in before the end of the call, we'll certainly do that.
All right, thank you.
And Gina Schimmel has her hand up.
Hi, Neil. Long time
Hi,
no talk. So I have a question. Is it, if we don't keep these stats, is it doable in terms of how many of the competency raised cases started on a welfare check so that we can see how they may have gone awry? And kind of a dovetail to that question is, are we tracking how many individuals are unhoused as well as need supportive services to return home? And if we could focus some of the projects on that, as a lot of individuals I see are in jail because they are unhoused with nowhere to go, and or it started as welfare checks from elderly parents and they can't return home without some type of supportive services. So are those things being tracked? Because I see a lot of those situations is where the police officers are filing charges.
That's a great question, Gina. So I think it's a yes and no, and I'll give a kind of a broad ranging answer with some specifics. The first part of your question, are they keeping data regarding welfare checks and where those? No, is the answer to that. As far as I know, Dan, Michelle, Megan can correct me, but I don't think we have data that fine grained that kind of drills down and says this is where this started. What we have started to see a lot of data on is that most of these cases, not surprisingly, have some sort of significant substance abuse component, but not the welfare check. So that's an interesting thing to talk about. We meet with both parties every month. That's something that we can certainly discuss with both parties going forward. The second part of your question about the unhoused population, the department is starting to keep data regarding that population. Early returns are exactly as you might suspect. Most people who are in the competency system have got a recent history of being unhoused. In California, I think it's north of 70% of people raised for competency unhoused. And so this is clearly a priority for this population to either divert away from competency by getting people housed and getting them stable and getting them services, or if they are found incompetent, but for housing could return to the community and continue restoration or have those charges dismissed. We need to have those options. So we have fines funded projects that support supportive housing in the Denver area, 52 different units. I think it's one of those things that we continue to prioritize. So as Dan mentioned, going forward with the fines funded initiatives, diversion deflection, housing, and then court expertise or competency dockets. Those seem to be the largest levers that we have. I also want to mention that the department has relatively recently, as we talked about, transitioning out of the COVID era and into the new kind of reality that we're in now. There's a significant amount of momentum and a significant amount of effort looking forward and trying to look at legislation, projects, initiatives that are pretty far reaching and will have, if everything, seems to hold promise in reality that it does on paper, likely would change the landscape significantly. We're not really at liberty to talk about those in detail, but they do hit at these kind of priority areas of diversion, housing, psychosocial resources, and court expertise, and so local expertise as well. So I wish we could give a little more detail that we just can't because some of those things are in process. But I do feel cautiously optimistic that the tide will turn again.
Yeah, Gina, I just want to affirm kind of the intuition behind your questions. You're exactly right. With respect to housing, the first thing the fines committee did was fund quite a bit of housing through CCH for people who are in the competence system, for folks who need restoration in the community, and housing was a barrier. There are now many units through CCH to help with that, and we feel like that was a good investment. That was certainly something that was important. Second, the welfare check, we don't, to our knowledge, have data on that, as Neil said. Amanda Edwards, maybe we can talk about some of that. I can tell you we've done some similar research in Virginia. Again, totally different state, but these phenomena are pretty comparable, and did find that there. As you, I think, are intuiting, there are so many scenarios where a welfare check somehow ends in an assault on a law enforcement officer charge, right? Because of spitting or resisting or whatever, and that then of course turns into a competence referral. So we did have some state data on that elsewhere. I don't know that holds true in Colorado, but I would expect that pattern is common in many states.
And just to respond to that, is Colorado is also in a unique situation that what would normally be a misdemeanor or municipal assault on a first responder elevates it to a crime of violence felony.
Yep. Which sets up barriers for diverting those, right? We've run into this a number of times. Yeah.
And that's why I really think if there's some way we can see how, if it's starting as a welfare check, just even how they go awry. And it's not necessarily, you have certain law enforcement officers who I think are being good, but they still are getting peace disturbance or other type of crimes that may have been happening, or a trespass on the scene and so on and so forth, just because they have nowhere to go, that the law enforcement officers go towards filing charges. But I think the other piece of that is also family members that are senior, that are taking care of severe and persistently mentally ill adult children, and then they can't go back home, for lack of better words. And so that is another group I see filtering into the competency end, because they end up being homeless. And what does it look like? So not just providing housing, but potentially even, is there more wraparound services? I know there is a bill that we have for families with children, but it totally ignores seniors who have adult, severe and persistently mentally ill adult children from getting that supportive services. So they're left out of that bill and that funding stream right now in our state. So just kind of an FYI, Neil, if that can be augmented to help those family members.
Yeah, thank you, Gina. There's a lot of things spinning at the legislature and things that have been recently introduced, and I think those are certainly worthy of consideration. There are some bright spots, and I want to acknowledge that, including Gina. You're passionate advocacy for this population for several years. It's not just intuition, as Dan nicely said, but it's born out of a lot of experience and care and concern. And there are some really good bright spots around the state that we don't have time to get into here, but do give us, cause for optimism and confidence that this thing can turn around. Shoot, I had another thought, but it's gone. It's evaporated.
Well, let me come back to you. Anybody else have a final question or two? We're about at time.
I remembered it.
There you
And it
go.
really is just echoing what Gina said and what other comments have been made on this session. The example you get about the person who's psychotic and being transported and has a minor run-in that elevates to a felony assault with a first responder. The person, again, pardon the lay language, kind of blunt phrasing, but it's mental health first, criminal second. And we need to realize that we need pathways and opportunities for these people to access treatment rather than facing a court for sometimes what are fairly minor charges that were levied in the midst of an acute mental health episode. People need to be held responsible and accountable for their behaviors. Yes. And I'm certainly not excusing any kind of violent behavior or illegal behavior, but I do want to have some sophistication within the mental health and judicial systems to be able to prioritize mental health needs when those seem to be the primary issue at play.
Yes, well, Neil, thank you for that. I mean, I think that the forensic system is well attuned, in fact, to this and doing lots of things to try and address it. Our concern is that we don't seem to see the same kind of engagement on the community side, and it's not just a question of diverting people who've committed some kind of an offense that could be a charge that makes them eligible for the forensic process and should be diverted. It's folks who really just need ongoing care and sometimes long-term residential support and that kind of supportive housing and care, so that they're not experiencing homelessness and exposed to the elements and conditions that lead to criminal offense on account of the lack of care, support, and services in the community. And I don't see that kind of civil side mobilization on as great a scale as I would like to see that would really meaningfully care for a needy population.
Well said.
So thank you so much. I want to be really respectful of everybody's time. We try to end promptly so that we encourage you to continue joining us and not fearing that you're going to be sucked into a meeting that's going to go on and on forever. We want to end before the 45-minute mark so that everybody's got time to squeeze in a bite of lunch or something like that before the next thing. I just wanted to mention a couple of things upcoming. We're hosting, in partnership with others, a virtual summit series next week. Rather than having 4-hour marathon summits, we're doing a series of 1-hour sessions over the course of the week. And this is a national summit focused on mental health excessive sentencing and the death penalty, and has a variety of different panels along that continuum. And one of the things that the summit will be driving home is that mental health is at issue not just with the defendants in the cases in question, but mental health more collectively across the whole span of people engaged in adjudicating folks who've got unmet health needs as a consequence of the circumstances of their lives. From corrections officials to judges to police officers, everybody's mental health is at issue in a system that is imbalanced as ours is. So it should be a great series with folks from all over. And then at the end of May, similarly, we're doing a series of free Friday afternoon national sessions focused on rural and frontier communities and their diversion efforts, because we know that the resources and needs and geographies of the rural and frontier communities are very different. We've done a lot of work with larger urban groups, so this will be a special focus on that. And we welcome you all to join. Emma's put the links to both in the chat, so please have a look and help us get the word out. These are free to all and will be recorded and available for viewing after if you can't make it. Anybody else have any final updates to share? Closing remarks from Neil or Dan?
I'll just say that it's a challenge. We appreciate everybody's input. We look forward to hearing ideas and solutions that you may have heard of, especially local solutions. That seems to be where the future lies. We appreciate everybody's interest and collaboration and trying to get through this thing together.
All right, well, thank you all so much for joining us. Thanks again, Neil and Dan. Thank you, Director Barnes, for being with us. Take care, everybody.
Pleasure. Thank
Thanks.
you.